This is Dr. Matthews, and today we're going to talk about pharmacology. Different branches of pharmacology. Pharmacodynamics addresses drug-induced responses within the body. Pharmacokinetics addresses the drug amounts at various sites in the body. Pharmacotherapeutics addresses the issues with choice and application of the drugs. Toxicology, study of response to poisons, and drugs can definitely be poisons. Pharmacy is involved in the preparation, compounding, dispensing, and record keeping of therapeutic drugs. And a pharmacist has to be extremely accurate with their keeping. Count pills down to the last. We have non-prescription drugs, over-the-counter drugs, aspirin, ibuprofen. Herbal supplements are not approved by the FDA, and I'm hesitant to take most herbal supplements. Prescription drugs are required by law to be prescribed by licensed practitioners. This could be a physician, a physician's assistant, a nurse practitioner, veterinarian, who have I left out? Dentist. But a veterinarian is not going to prescribe it to you, and the dentist is not going to prescribe it for your toe. It has to be for their own patient. Drug nomenclature means naming, if I didn't mention that. We have three types of names: the actual chemical name, the generic name, and then the proprietary or licensed drug name. This is an example here. We have amoxil. It's the non-proprietary name is amoxicillin. The chemical name I'm not even going to attempt. Therapeutic class is an antibiotic. Okay, sources of information about drugs. People, qualified, board certified, trained, licensed clinicians. They don't have to be board certified, but they do need to be licensed in what they're doing. And pharmacists. And when I say clinicians, nurses have a lot of information to give too. I'm not saying they don't, medical assistants, but ultimately your final choice of prescribing has to go to a practitioner, be it the doctor, the nurse practitioner, or the PA. Poison control centers are a pretty good source of information. Like, my kid just drank, what was it? Mine drank paint thinner when he was a baby, just a little slug, and he said, "Yum." And I called poison control, and they said, give him some milk, it ain't gonna hurt him. Well, we gave him some milk and carried him to the emergency room anyway, and it didn't hurt him, but, parents panic. Pharmaceutical sales rep, no. Listen to what they say, read the information, but they're hired to be full of bull. Okay, published information. Textbooks are generally good information if they're up to date. Things change daily, and really by the time a book, a reference book, or a textbook is published, they can be out of date. Newsletters, depends on what newsletter. Internet, I'll look up stuff on the internet all the time, but you've got to consider your source. There's a lot of garbage on the internet that has nothing to do with anything, and there's conspiracy theories and people who need to wear tinfoil hats, and just be cautious where you get your information. Look at your source and be sure it's legit. Principles of drug actions, they alter physiological activity, and they have to reach their intended target. If they don't, they're not going to work. And it's going to involve how the drug is administered, absorbed, if it's transformed in the body, distributed, and then eventually cleared. Drug administration, you can use local drugs, and they can be very good on the skin or mucous membranes. What is that? Anti-opiate attack drug? No, is it Narcan? I think that's right. There's a nose spray for that. So if you're having a heroin overdose, somebody can spray something up your nose. You're not going to be able to swallow a pill, and they work pretty well. Let's see, genitourinary tract. Any mucous membranes, a lot of drugs will absorb. When I worked my last veterinary job, if the animal was anesthetized on a table and fleas were hopping around, they needed to give it an immediate flea pill, which is Capstar, will kill the fleas by the time you get your patient prepped for the surgery. And it was their habit to put it in the anus of the animal, because you couldn't give it by mouth because the animal's already anesthetized. But anyway, it works beautifully. I just didn't want to do it myself because a lot of drugs are given orally. Some are inhaled, like if you have asthma. Iontophoretically is some kind of through the skin via ionic charges. I put electric zapping because that's what the pictures look like. Okay, transdermal. These are for systemic effects. Transdermal, a patch. Sublingual. A lot of drugs are given sublingual. Orally, very typical. And here we go, rectally. Inhalation. Gas anesthesia is inhalation. They don't get to choose to inhale it. You knock them down with propofol first, then put in a tube and hook them up to gas, endotracheal tube. Subcutaneously, intramuscular, intravenously, intrathecally into the subarachnoid space. So this would be like your spinal drugs. Subcutaneously, there are some drugs actually that are given intracutaneously, like the TB tests. And also the first experimental, I got my first rabies series was an experimental drug because they paid for it. Then they checked our titers and we had great titers and no one died, but they were given within the layers of the skin. It didn't really hurt. It was a tiny, tiny dose with a 27 gauge needle. Okay, they have to absorb and then proceed to the site. Has to be dissolved in bodily fluids and pass through biological barriers. One of the issues in giving oral medication to horses is a lot of drugs don't absorb if they're given orally because of the huge amount of the cecum has so many bacteria in it and it just takes it up. Sulfamethoxazole trimethoprim absorbs beautifully. There's probably others. And you can give injectable drugs to horses. Day 1, you give them a shot. And they say, ooh, that wasn't nice. Day 2, you give them a shot. They say, oh no. Day 3, you come with a shot. They say, no, I think I'd rather kick you. So oral is good or topical. Okay, rate of drug absorption is influenced by the surface area, how fast it will dissolve, whether it dissolves in lipids, and also blood flow to the particular area. Now, transfer of drugs across biological membranes depends on their chemical properties, such as water-soluble drugs are easily excreted by the kidneys, but they won't really readily get through the blood-brain barrier. This is going to be better for fat-soluble drugs. The anesthetic drugs, alcohol that people drink, these are generally going to be fat-soluble, and that's how they get to the brain. The placenta, sometimes some drugs cross the placental barrier and some don't. And it's important to know because you don't want to cause the fetus to get sick. And there was a drug, and I forget what it was, but they were giving to prevent miscarriages, and the babies, they were born, but they were born without arms and legs because of the drug. Biotransformation, this is how the drug is changed. It's metabolized. Liver is a big role in the breakdown of many drugs. Some lungs, like gas anesthesia, kidney, adrenal glands, and then the drug metabolites. If they're water soluble, they can be eliminated by the kidneys. Lipid soluble drugs may not be, or they're not going to be eliminated by the kidneys easily. They're probably going to be eliminated by the liver, the bile, through the gut. One thing about kidneys, if you have a renal failure patient and you have a drug that is eliminated by the kidneys, and the drug dosage is, let's say, 10 milligrams, 10 whatevers, and it gets them to this level of drug in their bloodstream, and you keep giving them that drug day after day and they're not getting rid of it, the level is going to get higher and higher and higher, and eventually you can have toxicity. So be very careful with your renal failure patients. This is talking about getting rid of drugs through the kidneys, glomerular filtration, resorption, and tubular secretion. Many drugs are metabolized in the liver, and they can be excreted from the bile and then via feces. Now, dose effect. Now, this is something I had forgotten. The dose is the amount you give at a single time. The dosage is the amount you give over a period of time. Therapeutic index, and there's some important stuff here that a lot of my students don't seem to have a clue about. Margin of safety. How close is the therapeutic dose to the toxic dose? Now, the effective dose 50, ED 50, and this should be, I forgot to do this, this should actually be like written like this, I wish I could write with these, D, and then the little 50 should be down here, 50. Same with the lethal dose 50. That's a 50. Anyway, the ED 50 is the dose required to be effective in 50% of patients, and we're going to assume they're lab rats. The LD 50 is the dosage required to kill 50% of lab rats. And there are those numbers available for most drugs. Parental pamoate, I mentioned, is the dewormer. In the form that's 50 milligrams per ml is what's available, 250 milligrams per 5 ml over the counter. In that form, it's impossible to get an LD50 on it. It's so non-toxic. You have to concentrate it into a higher concentration to make it be toxic. That's why it's over the counter. They actually put stomach tubes in these poor little rats, and they filled their stomach, and they kept giving it until it came out their backside, and they were just fine. It didn't hurt them. I guess they didn't have worms. But this next one should show more. Okay, if the therapeutic index and the effective dose is, say, 10 and the lethal dose is 80, you have a therapeutic index of 80 over 10. And that's a relatively safe dose. Now look over here at drug B. The effective dose is 10. Okay, we're looking at milligrams. They decided to give us that. The lethal dose, LD50, is 20, but some of your patients die at 10. This is probably not a drug that's going to ever get approved, but if it is, you don't want to give it to somebody you like. So look at the differences in the LD50 and the effective dose. Benadryl, even though it makes people stupid and drowsy and is not the best sleep aid, is used as a sleep aid a lot in the elderly because the LD50 is so incredibly high. And so if you have your effective dose over here, your LD50 is over here, and it'd take a lot to kill somebody with it. Okay, time response measures. Time of administration, and then how long it takes to work. Like an IV injection is going to work a lot faster than a pill. How long it lasts when it quits lasting, peak effect, the duration of action time, latency to effective time, and then the threshold level. These are times that are measured. And here's a nice little picture of it. This is a plasma concentration, and it's a time response curve. Here's when you gave the drug, right here. Latency, it ain't working. And this is the time it starts working, right in here. Let me get a little, this one. Starts working right here. And then the peak effect is out here. Then it quits working. You still have some in the body here. So, and if it's your post-surgical pain pill, I can promise you that the latency seems awfully long and the duration of action seems awfully short while you're sitting in the hospital. Okay, variability between drugs from one individual to the other, and as far as just in general. Toxic effects are going to be different on one person to the other. If they have liver or kidney disease, it's going to be a lot more toxic. Now, starvation, almost every drug in humans is so many milligrams per adult. Now, in children and in animals, we generally measure by milligrams per kilogram. If a person is starved, let's say an adult human weighs 90 pounds, another adult human weighs 200 pounds, and you give them the same dosage, which one is most apt to get the overdose? That's the 90-pound person. Age, and the older you get, probably the more toxic the drugs are. Genetics, some people just react differently. There's definitely genetic factors on how people respond to opiates, or maybe it's not genetic, but there's a familial association that some people, the opiates don't make them sleepy, they don't ease their pain, they give them nightmares and keep them awake, whereas other people, they turn into zombies. Gender factor, I have no idea on that. Species variability, I have a lot of ideas on that, and I'll give you one that's very interesting. A cat. We've got a drug, ketamine. It's used in animals. A cat gets can get up to let's see, of the 20 milligram. No, it's all 100 milligrams per kilogram. They can get 1 cc. A cow gets 2 cc's, and a horse can take 10. And they have similar effects, except the cow may die from overdose. Okay. Anyway, I'll erase those. They won't erase. I guess they're permanently embedded in your brain. Okay, toxicity, the effect can be acute. Now, you injected. I've seen this, but I'm not convinced it happened. As was said, the injection was given intravenously, supposedly, and the horse dropped off the end of the needle, dead. I wonder if they didn't get it, they were using a jugular vein, if they didn't actually get it intra-arterially. It takes talent to do that. I mean, it's hard to hit an artery, but it could happen. If you give a drug, an anesthetic drug or even an antibiotic that's supposed to go in a vein, and you give it into the carotid artery, it cannot be good for your patient. Subacute, you're getting toxicity that builds up over days. Chronic toxicity builds up over years. And this is the way arsenic is. It builds up over several months to years, and the person just has stomach aches. It takes them a long time to die. I've been reading mystery novels. Okay, Toxicology is the study of poisons, and it talks about different things like the physiochemical properties of poisons, routes and rates of administration, absorption, effects of chemicals in the air and in the environment. But many drugs are rejected before they ever get approved. Some drugs are approved in the UK before they're approved here, or vice versa. Scheduling of controlled substances, it doesn't really say anything here, but I do know Schedule 1 drugs are drugs that there's no known medical use for, and marijuana is in Schedule 1 nationally, federally. However, it is medical marijuana is approved in many, many states, and the medical marijuana oil is actually approved in Georgia. And I know a nurse, a pediatric hospice nurse, now talk about a heavy job, and she said the little babies that she's worked with will be seizing and they're in pain and they're crying, and you give them just a drop or two of that stuff just under their tongue and they'll just be happy. So it's certainly well worth it. It stops their seizure and stops their pain. Schedule 2 drugs are going to be things like your attention deficit drugs and some of your opiates. Schedule 4, your benzodiazepines, Valiums, and I can't think of anything in 3 and 5 right off. But that's all for now. Thank you.